So let's go through the counter, and I think you'll see at the end of this debate that maybe we won't confuse the crap out of you because there's probably more common ground than not. But I will argue with some of Miguel's points. And the first point I will argue with is that many patients, not the 10 to 15% of patients that Miguel just cited, have an indolent course after resection. And I'm showing you data from a recent study, so recent it just came out in inflammatory bowel diseases, looking at a pediatric-onset Crohn's population, so people who we believe probably are at risk for more aggressive disease, who have a first resection, an ileocecal resection, and then this group that included Jean-Fred Colombel looked at the probability of an second intestinal resection. And you see at 10 years, it was really only 30% of patients who needed a second intestinal resection. You say, well, so what? They were probably on medications that prevented this, which would be the tenet of Miguel's argument, right? Well, that wasn't the case. And if you look at the probability of the first use of an immunosuppressant or an anti-TNF in these pediatric patients, at 10 years, it was less than 50%. So we're talking about a fairly significant minority, or maybe even majority of patients after a first ileocecal resection that did not need potent medications, the medications that we believe, based on the evidence, were shown to work to prevent recurrence in postoperative Crohn's, and did not need a second surgery. So maybe we need to take a step back and think that it's not 80% of people who have this more aggressive course where there's an absolute need for medication. So this is data from the Rutgers study, just to remind you, when we look at these endoscopic scorings here, that the low-risk scorings of I0 and I1, which was a significant minority of patients in this study, roughly 20-30%, do not progress over time. So I think we could make a strong argument that there's a significant subset of disease that have relatively indolent course. Well, the second point is medications have not been shown to work to prevent clinical recurrence. And if you look at the data as a whole, and Miguel showed you this slide, but the important point that I want to make out, if you look at mesalamine, the nitroimidazoles, azathioprine 6-MP, both with clinical and endoscopic recurrence, in fact, the confidence intervals overlap with placebo. So in order to make an intervention, you need a good therapy, and the data for our standard conventional therapies have not really been shown to differ for placebo for either endoscopic or clinical recurrence. So let's move on to the TNF inhibitors. And Miguel made the argument that we have an opportunity perhaps to alter the natural course immediately if we initiate a TNF inhibitor immediately after surgery. And he showed you this data set with incredibly low recurrence rates with the TNF inhibitor, and he even expanded upon this with some adalimumab data, and talked a little bit about the clinical recurrence data in his study that I also participated in. And then he made the argument that, you know, if we wait for endoscopic recurrence, we may be missing an opportunity here. And he showed you this slide in terms of prevention versus treatment of endoscopic recurrence. It appears that we're doing less, but we're doing worse. But Miguel would really probably at the end of the day be the first to tell you we're really comparing apples and oranges here in very, very small analyses, and this is where there's some major data gaps here to tell who we should be treating and who we can wait for recurrence. And in fact, I think the most salient point when we talk about anti-TNFs, and I believe in my heart of hearts that this is going to be the best way of preventing postoperative recurrence and altering the natural course of disease, that even in Miguel's study, which as he showed you, it may be one of the few things I'm speaking from a position of knowledge because I did participate in it. If you look at the baseline demographics of these patients, in the there was a high percentage of active smokers. There was a high percentage of concomitant immunomodulator use. A third of patients had previous surgeries. 100% in the infliximab subgroup actually had evidence of perforating disease in the past. So these are bad actors. So we're looking at these numbers, but we cherry-picked this study, and Miguel would agree with this, to look for people who are at high risk for recurrence. So by the virtue of the study design in this small study, these were people who we thought at the beginning were already in Miguel's moderate to high risk group. These are people who were bad actors and were going to get into trouble. So this really does nothing to address, with Miguel's data, what happens in the low probability subgroup of patients. And so at the end of the day, Miguel agreed. And there is a subgroup of patients that have a low probability for clinical recurrence and endoscopic recurrence. And these are people who probably do not need medications right after surgery. So there's many unanswered questions here and many data gaps. Do we initiate treatment with endoscopic recurrence versus prophylaxis? Is it in everybody? Is it in a few? I think from the data I showed you, I'll make a strong argument, as I'm supposed to in this debate, that there's a significant minority of patients who have an indolent course who don't need medications. When do you look endoscopically? How often do you look endoscopically? And how do you adjust therapy based on your findings? These are all important and unanswered questions. And what's the best way to identify postoperative recurrence? Is it endoscopic? Should we be doing imaging? Are there biomarkers that would make all of our lives easy? And maybe the main question we need to discuss, if we're going to recommend therapy for everyone, what drugs work and what drugs work best. And Miguel told you that despite the fact that we have enthusiasm about infliximab and the TNF inhibitors, the jury is really still out, and we need to see these ongoing large definitive clinical trials. So what should we do in postoperative Crohn's? And again, this is where we're going to see agreement here. We assess risk. We look at disease location and behavior. We look at prior resections, smoking status, endoscopic recurrence. These are all important in our clinical decision making. And there's options. One option is no therapy for people who are low risk. Miguel agrees with me on this point. So a priori, I won this debate before it even started. With antibiotics, we need better efficacy and safety data. 5-ASA are likely ineffective. 6-MP and azathioprine, the data is extremely mixed. And infliximab and adalimumab, we're basing what we're doing on very small studies, and we await the larger studies. Wouldn't it be great if we had better assessments of postoperative risk? And Corey Siegel, Marla, and others have been looking at this, combining genetics, serological marker, immune responses with clinical criteria to come up with risk models. And I think the wave of the future is to be able to use a panel of biomarkers to be able to determine which patients we could just watch and which patients we have to be aggressive with in the future. And I think this is really key to better understanding this clinical problem. So at the end of the day, there is nothing but agreement here. There's a low-risk population who do not need medications postoperatively. We need to do a better job of figuring out who they are. In this day and age, we do this based on clinical criteria and what their natural history has been, although I showed you that interesting postoperative data from children with Crohn's disease who we believe may have a more aggressive course, where many of them do well with pediatric-onset Crohn's after a first resection for many years without medication. So it's an area that's important, it's an area that's evolving, and a game UNC. And I did it with a minute to spare, folks.